So let's go over some of the basics of keratoconus, that what is it and what to do about it. People ask me about it, people have been diagnosed with it, so I thought to bring it up to the attention of the audience as well. So what is the definition? What is keratoconus? It's a progressive eye condition or a disease in which the cornea gets thin and it bulges forward. So this is how the eye looks like, okay? Front to back. The front part, this part is called cornea. You see how it is shaped? Yep. So in keratoconus, this part gets super thin, and because it gets thin, it bulges forward, forming a cone. You see, right now it's not a cone, okay? It's not a cone. But in keratoconus, it turns into a cone. That's why we call it conus, keratoconus. What it does as a result is it affects the vision. It makes distortions. You see distortions in your visual acuity, in your vision. It's blurry and it's distorted from the sight. Your sight is distorted, and your vision, sometimes you have double vision, you have blurry vision, you have difficulty in focusing. So that's what actually entails this whole corneal thinning. Second thing is it increases your light sensitivity. You see a lot of glare, you have problems with focusing, you have frequent changes in your glasses prescription. So you are changing your prescription of the glasses or contacts every 3 months or so. That's not a good thing. If it's happening, it means keratoconus is about to hit or it has already hit. Doubling of the vision, halos around the lights. That's another problem. What are the causes and the risk factors? Family history. The genetics play a big role in it. Family history of keratoconus does have an impact on you. Environmental factors, the biggest environmental factors is allergies, because the more you rub your eyes, the more the thinning can happen for your cornea. And even if you are a habitual rubbing person of your eyes, you can get it. So don't rub your eyes, try to avoid as much as possible. Other patients that can get it are Down syndrome patients, Ehlers-Danlos patients, Marfan syndrome patients, they also get it. And the other thing is, how do you diagnose it? The refraction is the first thing. In the refraction, I have a thing called autorefractor that gives me a lot of Ks. Those K values in the refraction are quite important to me. But again, that's not end of the world. I need to examine it. I need to look at the cornea in the eye exam, the slit lamp exam, and then I have to do keratometry. Keratometry for that, keratometer does it for me. But autorefractor also gives me good case, but keratometer is more precise. If you don't have that, I understand. Corneal topography is the favorite. It's the most favorite test of mine. It gives a detailed map of the cornea. It's basically a corneal mapping. I love to map the cornea because that's how I decide what's going to benefit the patient the most. Okay, besides that, what's the treatment? The first and foremost important thing is eyeglasses, but as I mentioned earlier, the glasses prescription keeps changing. So that's why we need to switch to contacts, preferably hard contact lenses, especially in the later stages of that. RGPs or rigid gas permeable contacts are the good ones, but my favorite is scleral contact lenses. If you can get sclerals, they are way easier to handle compared to the RGPs. But either way, you need some hard thing in front of the cornea to reduce the bulge, to push the bulge back in there, because we don't want too much bulging. The more the bulging, the more the symptoms, as I described before. Corneal cross-linking is a surgical procedure. What they do in that is they manage this cornea, they strengthen it with a cross-linking procedure in there. Right in there, they do that. Another surgical procedure is Intacs. They are plastic kind of things that they put in this cornea to strengthen it so that it doesn't bulge forward. So to stop the bulge, they put some push factor in there so that it doesn't move forward. Okay. The last resort is the corneal transplant. Some people in the end stages where nothing works, they do end up with corneal transplants. But again, not everybody needs corneal transplants. I have seen a lot of patients, countless keratoconus patients, not all of them had cornea transplants. Very few, a handful of them, just a handful of them had it. Okay, so living with it, you have to know how to live with it. Regular eye exams are important. Protective eye mayors are important. You don't want to rub them all the time. You have to manage your allergies and find some support and resource groups. Talk to your doctor, they can connect you to that. Okay, in the end, early detection is most important, because earlier you treat, the better, and treatment is very crucial. So you have to treat appropriately, and the exact on-time management is important, because you want a quality vision. You don't want corneal transplant unless absolutely needed. And have a consultation with a cornea specialist. Cornea specialist consultation is my preferred to-go thing. And then once they clear us, then we switch to the preferred mode of treatment. For example, scleral contact lenses. That's the most preferred for the most cornea specialists at this point. So especially if you are having symptoms, please don't hesitate to talk to your doctor. Sometimes they need to step up. Okay, here are some of the references, and thank you so much for watching. And again, I just touch base the basics. I am sure there will be trillions of questions, so please ask me in the comment section. I will try my best to answer them. If not, I will direct you to somebody. Okay, thank you so much. Have a great day. Bye-bye.